Morning, everybody, and welcome to our Goodfellow Marathon webinar series, kindly supported by Mercy Ascot. My name is Dr. Grace Lee. Now, on to today's session. This morning, first off the bat, we have Dr. Orna McGinn, who is a general practitioner and clinical director of primary healthcare women's health at Auckland DHB. Welcome, Orna. She'll be talking on a contraception update, love in the time of COVID. And Orna, I'll now hand over the session to you.
Thanks very much, Grace, and thanks, Paul, in the background for doing all the IT. Mirena, everybody, thank you for tuning in on your morning off. I hope you're all sitting up in bed with a cup of coffee, ready for a bit of lockdown learning. We are going to talk about contraception. So I've entitled this talk "Love in the Time of COVID." So that is what we're going to be talking about, because people will still be having love in the time of COVID, and this contraception is a bit of an essential service, so it will be good if we can brush up our skills, I think. And I also want to just introduce a couple of accessory brains that I've got on standby for answering any questions that I can't answer. So one of those is Daphne Whitmore, who is a clinical nurse specialist who works with me at ADHB, who used to be employed by family planning and is an expert on contraception. And Helen Patterson, who's a gynecologist in Otago, and she runs the Te Waka Wahine Haora, which is the women's health bus. So between them and the resident gynecologist, who is the father of my children, who's sitting in the background here, we should be able to cover any curly questions that come up. So anyway, so we're just going to whip through these because I've only got 45 minutes and I'm sure there'll be quite a lot of questions. I was just going to bring this slide up because I was a bit sad to retire it after Mirena became funded, and then I realised actually we haven't completely solved the problem because we still haven't got insertion funded, so there are still some barriers to Mirena. But I did want to say that since Mirena became funded last November, there's been an enormous uptake, which did show that the funding of the device itself was the main barrier. So in the month after it was funded, use of Mirena went up 10 times, and then that was obviously because there was a sort of a lot of people in a holding pattern, knowing that funding was coming online. But since then it's settled to between 4 and 5 times the pre-funding level of use. So I mean, that's obviously going to change now we're in lockdown, but it did show that funding was a big issue. But the initial numbers that came through from Pharmac showed that even with that huge increase of numbers, only 6% of the women using it were Pacific. So it still does show there's a barrier, and that group of patients would potentially get an enormous benefit from Mirena because of its effect on prevention of endometrial hyperplasia. Anyway, we'll come back to Mirena later. So I'll just briefly mention the topics that we're going to cover. So if you've got any questions, hopefully you'll be able to look down the list and see that perhaps your question might be answered within these slides. So we're going to talk a little bit about the difference between Mirena and Jaydess, which one you might want to choose in which situation now that they're both funded. We're going to talk about extended use of Mirena and extended pill regimes, quick starting contraception, managing bleeding with Jaydess, the effect of contraception on obesity and effective obesity on contraception. We're going to talk about increasing the uptake of LARC in your practice, LARC obviously being long-acting reversible contraception. And just a little bit on IUD insertion, and I've said to be continued because before the Goodfellow Symposium was put on hold, I was going to be doing a workshop really focusing on IUD insertion training, and it's probably more suitable for a workshop, but I can just give you a few tips in the meantime anyway. Hopefully one day post-pandemic we'll be able to reschedule that. All right, so the reason even in these times contraception is important is because New Zealand has a very high rate of unplanned pregnancy. The rate overall is about 53%, which is higher than most people realise. And you can see at the extremes of age that the rate of unplanned pregnancy is very high indeed. And This is relevant because unplanned pregnancies are more likely to be complicated pregnancies. They are more likely to result in preterm delivery, problems with the fetal and maternal, mental and physical health. And it really, if we can go any way to preventing these, we will be doing not only our patients a favour, but actually in this particularly bad time when services are stretched, we will be doing our midwifery and our obstetric and gynecological colleagues a big favour. Because even though all routine services have been cancelled around the country, midwives are still working. They're still going to have to book these women in somehow. Our colleagues are still going to have to be dealing with ectopic pregnancies, you know, incomplete miscarriages, and our abortion services are still running. So if there's anything we can do to prevent this, we should do our best. It's particularly difficult at the moment because family planning clinics have shut around the country. They're still offering virtual consults, but it's going to be extremely difficult for women to get the full range of contraceptive services in the coming months. GP services are still open, so we will do what we can, but I think everyone has a different perception of risk, and there may be practices who feel that they don't want women coming in for LARCs, and we may be wanting to offer more oral contraception, and there's a few issues with that which I'll discuss further on. Okay, so I mean, what's going to happen? We just don't know. Are we going to get a lockdown baby boom? The evidence is kind of mixed, actually. Some natural disasters have resulted in a baby boom, and some haven't. So we just don't know, because this lockdown is likely to be lasting quite a long time, so we simply do not know. I mean, I think there is a likelihood that we are going to get quite a number of unplanned pregnancies because there is going to be a shortage of providers offering contraception. We already have a shortage of some forms of contraception. Noraday is currently not available, and that would be the commonest one, for instance, that midwives would prescribe postpartum. There's also a looming condom shortage because the countries where most condoms are made have had to shut down production, and that's China and Malaysia. So apparently we're 120 million condoms short worldwide at the moment, and you know, we just don't know what's going to happen. Anyway, so just to emphasize that the services that we provide for women with regards to contraception and sexual health are deemed essential, and this was a memo that came out from the Faculty of Sexual and Reproductive Health in the UK a few days ago, really just emphasizing that women being able to access contraception or being signposted to where they can get these services is vital. Emergency contraception is vital. Being able to counsel women on LARC and being able to offer them abortion services is still vital. And Mary Stopes in Australia brought out a similar document. And there is also a document going to the Director General of Health from DRCOG to say that those same things. So hopefully we'll be able to preserve a decent service for women in the coming months. Anyway, so let's have a talk about Mirena versus Jaydess now that we've got more of a choice of what we can offer women. So I thought I would do a little bit of a case, because this comes up quite a lot. Why would I offer someone a Jaydess when they can have a Mirena? Yeah, good question. I mean, when neither of them were funded, it was a bit of a no-brainer. You'd offer someone a Mirena because it lasted longer, and if you were going to have to pay for it, you might as well have five years worth. Anyway, so someone comes in to see, 23, nulliparous, and she wants to change from the pill to a LARC. Her periods don't really bother her, but after you've discussed all the different kinds of IUD, she says, well, I don't really want to get longer or heavier periods, so probably a Mirena or a Jaydess. So what might you say? Well, you'd probably tell her the difference between the two of them. Jaydess is smaller and slimmer, and that doesn't sound very much. When you look at the insertion tube diameter, 3.8 versus 4.4, but actually when you look at it, it's quite a difference. There's a lot less progestogen in it as well. So what I generally say to women is, if you If you really don't want any periods, Mirena is the one to go for because it's more likely to cause amenorrhea. The Jaydess will definitely lighten your periods, but it is less likely to result in amenorrhea. The other thing is, if you are a less confident inserter, you may feel more comfortable putting in a slimmer device in a nulliparous patient. I will say that with practice, there is so little difference in putting in a Mirena in a nulliparous patient versus a non-nulliparous patient. Overall, the rate of failure of insertion of an IUD is about 6%. And it really is, there's really not a lot of difference between nullips and non-nullips, and it's practice. But I do understand that it's difficult to get practice for various reasons. So if you are more comfortable putting in a slimmer device, then offer the Jaydess. But the Mirena I would still be offering to women who are at risk of endometrial hyperplasia, because Jaydess wouldn't really have the same effects. It has a much lower dose of progestogen in it. And obviously women at risk of endometrial hyperplasia are women who are obese or who have polycystic ovarian syndrome. Okay, so what about replacing Mirena? Well, this is relevant at the moment because if women are coming up for a change, new guidance from the Faculty of Reproductive Sexual Health says that you can actually leave that in for 6 years at the moment during the pandemic. And in fact, the other advice they came up with recently was that if a woman has a TT380, a copper TT380, which lasts 10 years, you can leave that in for an extra 2 years. The guidance on the 5-year multi-loads doesn't seem to suggest that you can leave them in any longer. So if you are not in a position to be able to change that, you could maybe do a dose of depot or put the woman on a progesterone-only pill in the meantime. So essentially, Mirena is licensed for 5 years, but you can leave it in for 6 years now. And if you look down the list there, if someone presents late for replacement and they're under 45, you can replace it immediately up to 7 years, as long as the pregnancy test is negative on that day, and then just send them home with a pregnancy test to repeat in 3 weeks. But if they present to you with it more than 7 years late, you will need a negative pregnancy test no sooner than 3 weeks after the last time they've had sex before you can, confidently replace that one. If a patient's not using it for contraception and it's for heavy menstrual bleeding only, and there's a lot of women out there who say they've had a tubal ligation, or the patient's had a partner's had a vasectomy and they've just got it in for heavy menstrual bleeding, you don't need to replace it at 5 years. You can literally leave it there until they are unhappy with the return of their bleeding, and then you replace it. And some people have Mirenas in for sort of 8, 9, 10 years. It's not going to go off or get infected. So you can leave that in there. All right, so I've just done a few little tips because again, I think this is probably better suited to a workshop situation, which I really hope to run one day. Peaceful partner, prostaglandins, pillow practice, and pain relief. So your peaceful partner is basically your vocal local. So if you've got a lovely calm assistant, it makes all the difference. So I might just put a shout out here to Ruth Cranwell, who for a long time was my vocal local in the contraception clinic I ran down in South Auckland. And if you've got someone like Ruth who just puts the patient at ease, it makes everything so much easier. Prostaglandin, I have to say, I don't think this makes much difference, to be quite honest. If you have someone you can't fit an IUD in, and again, the research says this is about 6% of cases, and certainly looking back through my last few years of IUD insertions, it wouldn't be much more than 6%. You can bring them back after them trying 2 PV tablets of mifepristone 4 hours beforehand. I've actually not found this very helpful, but it is something you can try. It's off license. Pillow, so that's just basically positioning the patient with a pillow under their pelvis. Sometimes getting a good position can make a difference. Pain relief, well, obviously you're going to ask them to take some anti-inflammatories beforehand, but here we're talking about anaesthetic during the procedure. Again, I'll be completely honest, I never use anaesthetic, and I haven't in 18 years of fitting IUDs, because it really doesn't seem to make a lot of difference. And I've had 4 IUDs myself, and the most painful ones are the ones where I had a dose of lidocaine in the cervix. So again, I think the most important key here is lots and lots and lots of practice, and then you gain confidence. But again, recognising that there are so many barriers to GPs getting both the training and then being able to offer this, that's increasingly hard to come by. But I do sincerely hope that that is going to change. Okay, let's talk a little bit about extended pill regimes.
Before we move on, Orna, sorry,
yeah.
I was just wondering if I could ask 1 or 2 questions.
Yeah.
There's a comment or a concern here with regards to the IUD getting buried in the uterus if it's left too long, making it difficult to remove with that extended placement.
No, that really doesn't seem to be a risk. I mean, that's no more likely to happen than if it's in for the duration. I mean, once it's in, they don't tend to migrate. It would be very unusual for them to start burrowing through the myometrium. So that really doesn't seem to be an issue.
Okay, and if a woman is advised that she doesn't need a replacement after 5 years and now is nearly 50 years old, how long do you think she needs to stay active? She needs the device to stay active to avoid pregnancy.
So if it's put in, if a copper IUD is put in over the age of 40, it can stay till the menopause, and if a Mirena is put in over the age of 45, it can stay till the menopause. And arbitrarily, we say 55. So you can just take it out then.
Okay, and I'll just do 1 more question before we carry on. Someone is commenting on a patient with low libido with Mirena. Is this a known side effect? And if so, how do we counteract it?
So libido is really complex. It's not just one thing. And the first thing I would always say when talking to a patient with low libido is take a really good history, because it's going to be multifactorial. Often, you know, you've got to take a good psychosexual history. You've got to talk to the woman about what her relationship is like. You know, what is her menopausal status? It's, you know, having a Mirena is going to be the absolute, you know, minimal least of contributory factor to libido, if you ask me, and the evidence confirms that as well. So yeah, it's not a big factor. But if you've excluded everything else and the patient is absolutely sure that the problem with the libido started when the Mirena was put in, I guess the only thing you can do is take it out and offer a non-hormonal method and see what happens. But sorry, Grace.
Sorry. Just one last, I know I said it was the last question, but just one last question. Any tips on retrieving lost strings?
I find this really difficult. If she wants to or Daphne, if they want to text in some tips, but I find this really difficult. And I can't remember the last time I actually managed to get one out with those thread retrievers. So
okay,
yeah,
thank you.
No tip, no particular tip there, except you can be relatively confident putting in the thread retrievers, because you know it's no different to putting in your sound, I suppose, and then you just have to gently keep trying to trap those threads in the notches of the thread retriever, but sometimes you just can't do it. And
okay.
those are only.
Helen Patterson has put through a few comments. She's mentioned that the Pelican works if the strings are long enough, and if not, you'll need to use a hook.
Thanks, Helen. And the old hook. Okay, should we go on and talk a little bit more about the
pill? Absolutely.
Okay, so yeah, I'm not a great big fan of the pill. I think the reason so many women are still on the pill, and it is the most commonly prescribed form of contraception in this country, the reason women are still on the pill is because they're just often not offered anything else. Because if you counsel women about other forms of contraception, particularly LARCs, most of them will choose a LARC. And all the evidence shows that. You know, the very well-known Choice study in the US, which looked at 10,000 women in St. Louis, when cost wasn't a barrier, 70% of the women in that study chose LARCs. So, but again, the barriers are if your GP doesn't offer them because hasn't had training and also doesn't know where to refer to, then it just doesn't get discussed in a consult. So people just carry on the pill for years, which is a shame when, you know, if someone's 38 and they've got 4 children, they don't want any more pregnancies. That's a good opportunity maybe to start talking to someone about a LARC. Anyway, so it's a bit old school, and having a 7-day break every month is even more old school. So really the advice I'm giving now is try cycling. So I think a lot of women are already doing this. You don't even need to have a full 7-day break. You can have just a 4-day break after 3 packets and get a short bleed. or flexible extended use, which means you can continually use the pill and you can rely on that after you've had 7 active pills. Then if you get breakthrough bleeding for more than 3 days, take 4 days off, have a proper bleed, and carry on going for as long as it takes for you to get another bit of breakthrough bleeding. And that's pretty much similar to 365-day pill taking. So if you take it every single day, you are more likely to get a little bit of breakthrough bleeding. But bearing in mind, we've just said that if you have a short break, then you will have a bleed, start back on the pill again. This decreases the failure rate of the pill. So this is what I encourage women to do now as well, because this is what happens. This is actually what happens in the 7-day break. If you have a 7-day break, your FSH, your follicle stimulating hormone, rises, and with a rise in FSH, obviously you've got more chance of developing a dominant follicle which could ovulate. That is not often happening in the 7-day break, but if you then forget your first pill at the beginning of the next packet, you've extended that break and you've got a ovulatory follicle, gets even bigger, you might ovulate. So it's much better to have shorter breaks. Because of course the other thing that happens in a 7-day break, apart from bleeding, is people get headaches, so or other issues, bleeding. So it's better either to have a shorter break or no break at all, if you possibly can. All right, let's talk about quick starting. That's a Porsche 918, quickest starting car in the world. Quick starting. So I've got a case just to illustrate this. This is a lady, typical lady, to come to my postnatal contraception clinic down in Mangere. She's 34. She's had 3 children. She's got a 10-week-old baby and she'd like a Jadal. So what do you need to ask when you're counselling her? Well, the most important things are, is she using any contraception? That would be the first one. Is she breastfeeding? And if so, is that partially or fully breastfeeding? And you want to know, has she had any unprotected sex if she's not using contraception in the last 5 days? In other words, does she need emergency contraception? Anyway, so you have established that she is mostly breastfeeding. She's doing some top-ups at night, so she's not fully breastfeeding. She hasn't had a period since the baby was born, not using any contraception. Today's pregnancy test is negative, and she really wants to have her Jadal today. She's got 3 kids, and it's very hard for her to get back to the clinic. So hopefully what you're going to do is quick start her. So when I was running this contraception clinic, I've always tried to quick start people because it's much better than getting them back for multiple appointments. So really, unless you've got a really good reason for not being able to start something that day, in other words, if you can't exclude pregnancy on that day, it's much better to send them away with some contraception. So you've got 2 choices here. So her pregnancy test is negative. Let's say that she's not had any unprotected sex in the last 10 days. It's still too soon for you to say that pregnancy test means that you are not pregnant. She will still need a repeat pregnancy test at a later date. But I would do that Jadal today. So what you could do is you could send her home with condoms or some other kind of bridging contraception. And then she could come back in 3 weeks' time for her Jadal as long as her pregnancy test is negative. Because you run the risk of her not coming back because she's really busy or other, life gets in the way, and then she's at risk of another pregnancy because we know she's, that is what might happen. Or my preferred method is I would put the Jadal in today, but say you can't rely on it for 7 days, and then I'll give her a pregnancy test for her to do in 3 weeks' time, and then I would text her to follow up and check that that is done. Even if she is pregnant and there's an early pregnancy there, a Jadal is not going to harm an early pregnancy. So that is what I always reassure patients. So really, you can't lose by sending them away, having quick started them with a Jadal. So this is what quick starting is. It's starting contraception at any other time other than a period. In the olden days, we used to only put in an IUD when someone was having a period, or put in a Jadal when someone's having a period, because you know that they're not pregnant. But again, I think we really should be quick starting everyone unless you possibly can't. If you send someone away without decent contraception, they may have a change of heart or forget your instructions or just lose their enthusiasm. It's much easier for the patient to come and have a one-stop shop. So when can you do this? You can start contraception at any time if you can reasonably exclude pregnancy. So you're reasonably excluding it on the history that the patient gives you on that day. And this is how you reasonably exclude pregnancy, according to the WHO. So if a woman is within 7 days of a period, she hasn't had sex since the period started, she's been 4 weeks of having a baby, she's fully breastfeeding and hasn't had a period since she's had her baby, which is less than 6 months old, and she's correctly and consistently using, or she is correctly and consistently using some form of contraception, which does include condoms, you can quick start. And the other thing I'll say about the lactational amenorrheic method, which is where a woman is fully breastfeeding, hasn't had a period, and the baby's less than 6 months old, is that the failure rate of that is very low. So that in itself is actually a very reliable method of contraception, bizarrely. The failure rate is something like 2%. So, you know, it's worth getting a good history of the breastfeeding. All right, let's talk a little bit about bleeding with Jaydess. So Maria has had her Jaydess in. 6 months later, she comes back. Again, quite common, about 15% of women have their Jaydess removed because of bleeding. So she's been bleeding every day, completely fed up, wants it out. How would you manage the bleeding? Well, what I would do first of all is I would have said to Maria when I first saw her, please come back if you get any bleeding, because if you counsel women this might happen and reassure them that there's lots of things you can do about that, they will come back early before they've lost faith in the method. So I would be sad if someone put up with it for 6 months before coming in. But anyway, when they do come back, and this is the counselling that you would say when you are putting the Jaydess, about 20% have no periods at all, but about 20% do get prolonged bleeding, and I do always tell people that, because you know it's a shame if someone has it removed, such a good method of contraception, because of bleeding, when there's something you can do about it. So this is the best available current advice about how to manage bleeding with Jaydess. So you can put someone on a pill, you can keep someone on the pill because they don't have to remember it every day. You can just use it as a bit of a backup. The Jaydess actually doing the contraception job. And then we've got mefenamic acid or tranexamic acid, norepinephrine. You can put someone on the pill, a progesterone-only pill, and all of those should help. But sometimes, you know, you just have to remove that Jaydess and go for another option. But again, I think with the current situation, you'd probably be trying to manage someone for as long as possible. All right. Oh, and then just a little bit about where you're going to put the Jaydess. So there was a spate of poorly placed Jaydess going walkabout in the UK a couple of years back, and so the Clinical Effectiveness Unit of the faculty in the UK put out some guidance as to who should be fitting them and where they should go. And again, when I was taught about 15 years ago to put in the implanons in the UK, we were told to put them in the sulcus between the biceps and the triceps. But as you can see from the diagram of my gentleman friend, there are things in the sulcus that you want to avoid. So now the advice is that we put our Jaydess in over the biceps, so superior to that sulcus. And obviously you put it in subdermally because you don't want it sitting in the muscle or, you know, going somewhere that you can't retrieve it. So this is what was happening in the UK. There were a number of case reports around the world of those. That's actually a Nexplanon. Nexplanon's being put in deeply, getting into the brachial artery and traveling to the lungs, which obviously is, you know, not a great outcome. So if you're not already putting your Jaydess in over the biceps rather than in the sulcus, it's probably a good time to start thinking about that. All right, a little bit about weight. So the weight of the patient doesn't affect the pill, the combined pill, or the mini pill, the depot, IUD, or Jaydess. There was for a time, and again, Daphne and Helen might hopefully have this, agree with me here. There was for a time information saying that we needed to reinsert Jaydess at 4 years because of weight, but I don't think there was any strong evidence about that. I think in the last year of use, the amount of progestogen hormone in blood was lower in people over 70 kilos, but I don't think this resulted in an increased number of pregnancies. So, so again, I don't think there's any need to reinsert the Jaydess at 4 years. And again, there's a cost implication for patients anyway, because most patients have to pay for these removals and reinsertions. Only depot causes weight gain. One instance where weight is relevant is with emergency contraception. We're advised to give 2 if a woman is over 70 kilos. The other thing to remember is the pill is MEC3, i.e. Don't use them unless you really have to, if a woman's BMI is over 35. If someone's had bariatric surgery, non-oral methods are preferable because there are some queries about absorption being affected of the pill. Stop the pill 4 weeks before any surgery. That's a good one. Oh, and I've just highlighted at the bottom, if you are thinking of emergency contraception for a woman and you are in a position to offer an emergency IUD, the copper IUD is so much more effective, and then you can leave it in afterwards for a long-term method of contraception. The failure rate of the copper IUD is about 0.1, 0.2%. The failure rate of emergency contraception is anything up to 15%. And if you give it at or after the time of ovulation, it's no better than placebo. So again, if you are giving emergency contraception, get a really good history of obviously the unprotected sex, but also, and when that was, but also of the woman's cycle, so you can work out whether and when she may have ovulated. And if it's around the time of ovulation, if you possibly can refer her to a service where she'll get a post-coital IUD, she'll have a better outcome. And that diagram there is just explaining the copper IUD's effect as emergency contraception. So if you look, an egg gets fertilized in the tube and it travels along, and the earliest it's going to implant really is maybe about 7 days later. And this is why you can use the copper IUD up to 5 days after unprotected sex, because it's going to take more than 5 days for that fertilized egg to travel down the tube and implant. So if you get your copper IUD in before the implantation, you are going to prevent that implantation. So I hope that makes sense. I'm quite visual, so I like to see how things happen, and to me that's a really good diagram. All right, how do you increase the uptake of LARC, the most effective method of contraception? Well, basically you offer it, because if you offer it and you explain, its effectiveness, most women are going to go for something they don't have to remember every day. I mean, if you're not planning a pregnancy, you have to take a tablet every day to stop a pregnancy. Seems a bit counterintuitive, doesn't it? So whenever you have an opportunity, I would mention it. So anytime any woman comes for her appointment for any other form of contraception, we've got fabulous nurses in my practice, and they do all the 6-week immunisations, as you can imagine, and the immunisations for our pregnant women at 28 weeks. And they all talk to all the women about contraception, and that's how we get a lot of our referrals for LARCs from our practice nurses. Think about it, in any women who are on teratogenic medication or anything that will be unsafe in pregnancy, or any condition that will be worsened by pregnancy, and if you can't offer it yourself, know where or where to refer to if there are no inserters at your practice. And we all must be advocating for funding, and this is more important than ever with the situation we're in, where the national provider has had to shut its doors. This is really an accident waiting to happen, and because primary care up until now hasn't been funded, there are very few places for women to go. So we must all be highlighting this, I think. Okay, so the barriers which exist are lack of funding. At the moment, there's no training pathway, as we know, although the Ministry of Health has been looking into this, but again, it's going to be on hold, I'd say, for at least another year now. Women have a transport issue, getting to services, more of a transport issue now. And it's very hard for women to navigate a very complex system. And this is a sort of diagram. There's a name for these diagrams. Do you know what the name for these diagrams are? No. oh, somebody's going to tell me. But anyway, this is kind of the patient journey. You can see how complex it is. Someone tries to get good contraception, they're turned away because the practice doesn't have staff who are trained, or the GP doesn't offer the one particular method that she wants, so she can't get the contraception she needs. She gets something else, she doesn't like it, she stops using it, she may get pregnant, or she may decide not to use anything at all, then she may get pregnant. So it's a real shame. This is basic stuff. There are not many other things that we prescribe which have a 99.9% chance of doing what they say they're going to do. I mean, there's no way that aspirin will prevent 99.9% of strokes, or a statin will prevent 99.9% of MIs. So this is really basic healthcare. It's really basic public health. So there we are. But anyway, I never moan without offering solutions. So my solution is advocate for funding, talk to your PHOs about training, and we'll get there in the end. And because this is a contraception update, I thought I would mention the future. Although, it did take 20 years for Mirena to get funded, so I'd say we're probably, this might be one for our grandchildren. But in the UK at the moment, there are trials going on of a male contraceptive gel which prevents or stops production of sperm, and it's actually showing really positive results. And the 100 couples that they've recruited on the trials have been very, very positive about it. So that's interesting. But as I say, don't hold your breath, because it won't be coming here anytime soon. But it's just FYI. Okay, so that's all my slides, and I'm always really happy to get questions or comments, and that's my email address, and I'm on Twitter as well. So I hope that has been helpful. Actually, just a couple of other things I might mention. There is a nationwide shortage of Noriday. I haven't mentioned that, but Microlute is funded, and if people were asking what's an alternative, and obviously Sarazet, but that's not funded. The other thing is there may be some pharmacists listening as well, and I think I'm correct in saying that at the moment pharmacies are only allowed to issue 1 month of every prescription, no matter what it is. So
the pills for 3 months. I read it.
Oh, is that right?
Yeah.
Oh, apparently that doesn't include the combined oral contraceptive. But again, if there's any pharmacists listening, it would be good to clear that up.
Okay, I'll keep an eye out for that. We have a torrent of questions that have come through. I thought, however, it was really important that we all got let you go through your slides, because it's got lots of really interesting information that we can go back to after this webinar has been recorded and put on our website. So I'm just going to pick a few out. With regards to your case study, there was a question, or a couple of people asking about why do we need to stop the oral contraceptive prior to bariatric surgery. So if you could just comment on that, that would be great.
Oh, that's because there is, oh no, not prior to bariatric surgery. Prior to
surgery. Sorry, prior to surgery.
Oh, because it's a DVT risk. So,
Great.
okay. It's not a DVT risk 4 weeks before surgery. I mean, again, I think in practice we all forget about this, but I'm just putting it out there because that's the advice.
Okay, and someone's commented taking a shorter break confuses patients because they get out of sync of the days of the week, which is printed on the pill packet. Any advice there?
The days of the week, well, I mean, it has to suit the patient. At the end of the day, whatever makes them remember the pill is the most important thing. But if you're taking a regime where you are having much shorter breaks and much longer time where you are taking the pill every day, your chance of an escape ovulation is so much less. So because you are sort of putting your ovarian function into hibernation. So do you see what I mean? It doesn't matter if you miss the odd one, because you're really going to have to miss 7 or more in order to be at risk of an ovulation. And that's not going to happen if you get 7. So it's actually much easier. I mean, when I talk to patients, they find that much easier to take it every day till they have a bit of bleeding, 3 or 4 days off, then go back on it again. And then it doesn't matter what day of the week it is.
Okay, and for our patients that are postpartum who are offered the progesterone-only pill, how common is it to have breakthrough bleeding? And if so, how do we manage it? If they do get it, how do we manage it?
How do you manage breakthrough bleeding if someone's postpartum? Well, it's really variable, because if they're breastfeeding, they are quite likely to be amenorrheic, And if they get so if they're postpartum and they're getting breakthrough bleeding, the other thing to mention is you can actually start the combined oral contraceptive 6 weeks postpartum. So if someone's got breakthrough bleeding, it is an option to switch them onto that. The only, there's actually very little effect, if no effect at all, on breast milk production. Because I think this was one of the reasons why people thought that the combined oral contraceptive was, not advisable. But actually, it's the DVT risk, and that DVT risk is largely reduced by 6 weeks. So you can go onto the combined oral contraceptive at 6 weeks, and then obviously you're going to get in a better pattern with breakthrough bleeding. Does that have any help?
Great. Yes, and we've got a little bit of feedback with regards to the prescriptions. Yes, it is 3 months for the pill.
Oh, that's
so
so good.
right.
So that's from a pharmacist.
Sorry?
Oh, just wondering if that was from a pharmacist, because I know often they listen to the webinars.
Helen Patterson has commented on that, and there may be a few pharmacists there as well, just also backing that up.
Great, thank you, Helen.
Okay, so a few more tips. Someone's just mentioned that I tell my teenage students to cut the 7 days of inactive pills to help facilitate continuous use, so I think that's quite useful.
That is a really good tip, and that was a tip I heard from family planning as well. If you cut out those sugar pills, because often they forget which ones are which, so yeah, they can't make a mistake if you literally cut them off the packet. I agree.
And Dr. Arnold Sharma's also commented with regards to removing the strings, just a thought, he likes to use the Emmett thread retriever, and his preference is to use a little bit of local anaesthetic and try slightly bending, hope this makes sense to you, bending the plastic retriever, and the hook can also work but may cause a little bit more trauma.
Okay, thank you, Anil, that's helpful.
Okay, we've got quite a few questions coming through and just trying to sort of sort some of them out. Just a little bit of clarification for some individuals out there that need a bit of a reminder for women over 70 kgs with the 2 emergency contraceptive pills. Alongside with that, just wondering about whether or not we need to increase the dose of the progesterone-only pill for women with higher BMIs.
No, the advice is that weight doesn't have any effect on the progesterone-only pill's efficacy, so you don't need to take 2. But the ECP, yeah, you need to take 2 now. Again, the UK advice is you may consider 2, but you know, I think I prefer a nice clear guideline, and here the advice is take 2. That's what family planning is advising.
Okay.
Family planning are the source of truth.
Fair enough, fair enough. And alongside, there's been quite a few questions about training with regards to health professionals wondering where further resources, information and training sessions. Is there a list somewhere that we can access? Are there places that you can recommend?
Okay, this is it's a real shame because this was coming online this year, and I think it's just going to be put off. My advice is do the online learning, which BPAC have got a great resource, and then obviously there's the ones on Goodfellow site. Disclaimer, I wrote those. And coming soon there will be workshops, so you obviously need practical workshops to practice on. And then what we were teeing up in Auckland was coming to one of our free DHB clinics and doing training there, but obviously they are now they're now offline. So I think there is really going to be no opportunity for training during this pandemic, but after that we will definitely get it up and running because it's long overdue.
Great. And just a question about breakthrough bleeding. Can we use Provera as an option to manage a breakthrough bleeding with the Jadel and the Mirena?
Yeah, absolutely. You can use Provera. Did I not put that in the option? So you can use 5 milligrams TDS, or you can sometimes use larger doses.
You can use as much as you want.
You can use as much as you want, says the gynecologist here in the background.
Oh, lovely. Excellent.
Yeah,
okay.
Like 30 CDS would be fine.
Even up to 30 TDS.
But sometimes they have a lack of estrogen, so the combined might be better.
Right. Yeah, so you can use up to 30 TDS if you need to. Then obviously
You've
run the risk of more side effects like bloating and breast tenderness.
Okay. All right. Helen Patterson has just texted through saying, if you live in the southern region, the Women's Health Bus and the PHO have been training and will start again post-COVID. So that's nice to know.
That is nice to know, and you can follow the Women's Health Bus on Facebook if you want to have a look, and maybe Helen will post what she's up to.
Great, great. Okay, any last comments or advice for us, Orna, in this particular space?
I suppose just generally, I'd want to say to everybody, be safe. And I know that GPs are facing a real loss of income actually with less patients coming in. CBAC centres really need you. So if you want to look at working at your local community-based assessment centre, you can contact your DHB or PHO, and I'm going off after this to work at R1 in Botany. So that's just a little tip. Anyway, thank you for tuning in on your Saturday morning, and it's nice to be Brian Betty's warm-up act. I'm looking forward to his talk.
Thank you so much for joining us today, Orna. We'll see you all soon. Thank you.